So this video will be on what is meant by pre-opping a patient. Before we get started, please remember that the information provided in this video is for educational purposes only and should not be considered a substitute for professional medical advice, diagnosis, or treatment. During residency, especially as an intern, your job, first and foremost, is to adequately pre-op a patient. This is the part where if you were to make a mistake, it could result in a surgery being canceled or delayed and cause a lot of frustration amongst your team. Even worse, the patient has the potential to be hurt. What are the things that should be ordered for the patient and what things have to be considered? First, I always start with anticoagulation. Is the patient on any anticoagulation and does it need to be stopped well ahead of time? Considering this can allow you to look to the future as this patient may be scheduled a week in advance and you are not focused on the pre-op of this patient yet. Good rule of thumb, DVT prophylaxis is okay to keep all the way to the day of surgery. This is your sub-Q heparin dose, the standard 5,000 unit dose, and standard Lovenox dose. Aspirin is generally well tolerated and advised to stay on, but some surgeons may choose to stop this. This will not significantly delay your case. Anticoagulants, like Eliquis, Xarelto, need to be stopped at least 2 days prior to surgery. Warfarin should be stopped 5 days prior to surgery. Consider putting these patients on a heparin drip based on their comorbidity that they have placed on this anticoagulant for. Antiplatelets typically take at least 5 days to wash out, so thus they must be stopped at least 5 days prior to surgery. For patients with recent stents, you may consider placing the patient on a cangrelor drip. This drip has a half-life of only a few minutes. Or consider a ergatroban drip, where the half-life is a few hours, so this patient can have that stopped at an appropriate time, whether it be a few minutes before the OR or a few hours before the OR. Talk to your seniors or attending about confusion on anticoagulation so they are aware, as well as help you guide toward appropriate intermediary care while placing these products on hold. Next, I make sure the patient has an active type and screen. If not present, order a type and screen, a PT-INR, and a PTT. There are studies that suggest that PT-INR and PTT may be unnecessary if a patient is not taking anticoagulation that blocks the intrinsic or extrinsic clotting pathway, or some evidence of metabolic disorder affecting those levels. However, please refer to your residency guidelines and what they want you to order. In my program, they would like every patient to have a PT-INR and PTT and type and screen within 3 days of surgery. Next, ensure the patient has labs ordered for the day of surgery, a CBC, and a chem panel. Consider CMP if concerned of liver function studies, such as patients with gallstones. Next, if the patient is relatively young and female, the average age of menopause is 52, and the upper average is 55. So if they are below 55, I absolutely get a pregnancy test. Urine is fine for the day of surgery, but can get serum HCG, as some institutions allow this to count for a longer period of time than the regular urine test. Next are the adjuncts. Look at chest x-ray and EKG. Most patients that come through the ED come to you likely have both of these. If they do not, there's a list of criteria that allows you to ascertain if the patient needs this. Rule of thumb, if they are older or have a history of cardiopulmonary disorders, order the EKG and chest x-ray. The exact criteria is as follows. For an EKG, consider age over 40 years old. Cardiac history, including CAD, MI, heart failure, or arrhythmias. If they have any type of chest pain, dyspnea, or palpitations, if they have surgery you're planning has a high cardiovascular risk, such as vascular surgery, and consider comorbidities such as diabetes, hypertension, chronic lung disease. For the chest x-ray, here the age threshold is 50. If they have any respiratory symptoms such as persistent cough, dyspnea, or hemoptysis, if they have a history of lung disease, if the surgery is a high-risk procedure such as a thoracic surgery in the chest or upper abdominal surgery. Next, consider stress dose steroids. Does the patient take daily steroids? More than 3 weeks and greater than 20 milligrams of prednisone or equivalent every day? There are also nuances to this being added on in general. For these patients, for minor surgery, can give them 25 to 50 milligrams IV before surgery and 25 milligrams Q8 for 1 to 2 days. For major surgery, use hydrocortisone at 100 milligrams IV before surgery, then 50 milligrams every 8 hours for 1 to 2 days. You may need to taper these steroids based off your patient's condition back to their normal dose. but you can consult your endocrine colleagues after the surgery once you have more time. Lastly is the topic of medical clearances or risk stratification. Essentially, you can call cardiology, pulmonology, or internal medicine to optimize your patient for surgery and give a risk stratification. They will see your patient and advise you with the risk of the patient's comorbidity in association with the surgery. This can be used to consult your patient. Ideally, you'd want to consult cardio when the patient has a history of heart failure, unstable angina, significant uncontrolled arrhythmias. You can also consult them if the patient has a low functional capacity to see if they would like to perform additional testing such as a stress test, echo, or a left heart cath. You ideally want to consult pulmonology when the patient has a history of severe COPD, asthma, or chronic lung disease that's not easily controlled. Additionally, you can consult them for high-risk procedures such as in thoracic surgery. Usually, however, in inpatient settings, they're typically already involved. You ideally want to consult internal medicine if you have a patient with several significant comorbidities such as diabetes, hypertension, CKD that may complicate anesthesia or surgery. These physicians can better assist in optimizing your inpatient meds as well as make changes for their meds for dispo if necessary. This is all you need to consider for pre-oping the average patient. However, remember that certain patients, you also need to consider mechanical or antibiotic bowel prep. You may need to consider further imaging, such as vein mapping and vascular surgery, and so forth. The exact pre-op for a patient may vary based on specialty, surgeon, or hospital. Lastly, don't forget about your pre-op or peri-op antibiotics. Rule of thumb is ANSA for most things, Cefepime for bowel surgeries, and clindamycin for those patients that are allergic to penicillin. Order on call for surgery. As you spend more time in these settings, it will make more sense to you, but remember the core principles discussed in this video. Thanks for watching. If you found this video helpful, please like, subscribe, and leave any questions or comments below. And I'll see you in the next video.